Good evening, everyone present here. So, sir, you can start sharing your PPT. We'll be starting now. So, as per the topic for today is environment hazards and toxicology, and it will be
हमारे जो लैब का एक छोटा फॉर्म रहता है
Dr. Swarnendu De.
उसको बंदा होनी चाहिए।
Hi, can you hear me?
Yes, sir, you're audible. Uh,
Okay,
Aspirants, he is a anesthetic registrar at NHS.
right. Are my slides visible to you?
Yes, sir.
Okay. Does it say environmental hazards and toxicity? Toxicology. Yeah. All right. Just give me a thumbs up if you can, if I'm audible and my slides are visible to you, please. Okay. So I'm all right to start then. Yeah. Fine. Good evening, everyone. I'm Swarnindu Day. I am originally from India, where I've done my MBBS and MD in anesthesia from. Then I moved to the UK, and I'm currently working as a registrar in anesthesia and intensive care in the NHS. A bit of a disclaimer: this is for the EDIC preparation, but I haven't taken the EDIC. I've instead done the FICM, which is the Faculty of Intensive Care Medicine in the UK examination. But I believe the syllabus for both these exams are very similar, which I've confirmed with Fars Academy, and which is why they're happy for me to go ahead and take these lessons. So the topic to cover for today is environmental hazards and toxicology. This is quite a big topic, and my presentation has more than 100 slides actually. So I've decided to divide it into two classes. So the first lecture is today, and each class will be around 45 minutes or so. And so in the second lecture, I'll confirm the date later on. I will do the rest of the topic along with some multiple choice questions as well. So starting with, so what exactly I'm going to cover. So firstly, I'll cover environmental poisons, and then toxicology, which will be subdivided into following topics: overview of poisoning, psychiatric medication, recreational drugs, serotonin syndrome, cardiovascular medications, local anesthetic systemic toxicity, paracetamol, and salicylate toxicity. And lastly, very briefly about propofol infusion syndrome and TURP syndrome. So that's the broad overall topics for the sessions, but I'm going to, like I said, I'm going to divide it into two classes of 45 minutes each. Now, starting with environmental toxins, uh, the corrosive ingestion is relevant to critical care. I'll divide it into the following topics. There's of course corrosive ingestion, which is relevant to critical care, acute heavy metal ingestion, chemical agents, biological agents, and acute radiation syndrome. Now, what is the difference between poisoning and envenomation? It's basically in the difference in mode of entry. Poison enters via ingestion or topical absorption, whereas envenomation occurs due to contact with animals, example, spiders, snakes, insects, jellyfish, and effects are due to the neurotoxin activity, rhabdomyolysis, and anticoagulation. The basics of management is pretty much the same. It's prompt recognition, investigation, and supportive care, and application of pressure, which leading to immobilization by first aid bandage, because most of the venom remains subcutaneous. Antivenom administration, need hemodynamic support because cardiovascular collapse is likely with antivenom. Transfusion, because a lot of the times hemorrhage and coagulopathy can be seen as well during these envenomation episodes. Good pain relief and antibiotic and tetanus prophylaxis as well. Now, corrosive agents relevant to critical care are typically readily available household items and they're potentially life-threatening because they lead to airway compromise, GI perforation, specific effects, for example, GI stricture, perforation, shock, mediastinitis, and multi-organ failure. Specific care, firstly, decontamination with oral rinse only, avoidance of blind GI procedures, early airway intervention, endoscopy, and surgery. Now, coming to the next topic, which is heavy metal poisoning. I'll start with iron, which is quite a commonly available item in household. Accidental ingestion is the most common way of presentation, which leads to free radical production, and it also impairs mitochondrial function. Clinical features include typically GI symptoms like nausea and vomiting, diarrhea, hematemesis. This is followed by an asymptomatic phase. However, severe toxicity, which can result from ingestion of very heavy doses of iron, leads to myocardial depression because of direct cardiac toxicity, vasodilatation, hypovolemia, coagulopathy, and hepatotoxicity, which may lead to necrosis or cirrhosis. Other heavy metals include lead. Lead can have acute and chronic manifestations, envenomation with lead. So acute lead encephalopathy, acute envenomation leads to lead encephalopathy and cardiovascular collapse, whereas chronic exposure, mostly from water source, leads to neuromuscular dysfunction and multi-organ failure. The treatment is gastric decontamination and IV or oral chelating agents. I'll come to the chelating agents a bit later on. Arsenic typically presents with hypersalivation or garlic odor, may lead to encephalopathy, seizures, myopathy, bone marrow failure, and ascending peripheral neuropathy. Now, specific management of the heavy metal poisoning. So, specific management include X-ray imaging. Sometimes you need to do serial imaging as well to ensure complete elimination. Prokinetics, again, to ensure gut movement and elimination. Endoscopy may also be needed at times. Iron, specifically for iron, there's chelation with the desferrioxamine. Typical dose is 50 milligram per kilo over 12 to 24 hours. If serum iron is greater than 90 millimoles per liter, but one has to be careful about because it may cause an anaphylactic reaction. And arsenic chelation with succimer, which is dimercaptosuccinic acid or DMSA or dimercaprol. And finally, surgery may also be needed if in case the substance is not being eliminated from the body. Chemical weapons relevant to critical care, which is the next topic. Now, they can be weaponized or non-weaponized. They can be classified as damaging, which is impact on resources, for example, mustard gas, low-dose radiation, or incapacitating, which is in temporary inability to function, or lethal, for example, cyanide, nerve gases, phosgene, anthrax, etc. Now, nerve agents, for example, rapid-acting organophosphorus, irreversibly bind to the anticholinesterase, for example, sarin, which is a typical nerve agent, and which leads to cholinergic, which is muscarinic and nicotinic toxidrome. Now, toxidrome is what is toxidrome? It's a collection of signs and symptoms which typically occur with poisoning. I'll discuss toxidromes later in my talk. But chemical weapons like sarin, which is a nerve agent, typically presents with cholinergic toxidrome. And the management is antagonistic anticholinergic medications, for example, atropine infusion. Right? And the specific treatment is cholinesterase reactivators, for example, pralidoxime and obidoxime. Now, the next one is cyanide. A cyanide typically inhibits cytochrome oxidase, which impairs aerobic respiration, that is, causes asphyxiation, which leads to refractory lactic acidosis. Hydrogen cyanide, which is highly volatile, it happens in when there is burns in the enclosed spaces, for example, fire in the enclosed spaces, and it poisons typically by the inhalational route. The management is oxygen, and the specific antidotes include hydroxycobalamin, which is B12, which is the first line, dicobalt editate, and sodium nitrite. I'll discuss more on these later on, how exactly they work, because this is quite an important topic in terms of examination. They might ask you about cyanide poisoning and how each of these agents work. So I'll talk more about them later on in my talk. Other chemical weapons include vesicants or blistering agent, for example, mustard gas, pulmonary or choking agents, for example, chloride and phosgene, and the management is mostly supportive. Inhaled toxins, which is the next topic. So inhaled toxins include carbon monoxide, which is typically produced and in fires. For example, if there's a fire, it leads to incomplete combustion of materials, and it leads to carbon monoxide formation. Typically, it could be mild, moderate, or severe intoxication with carbon monoxide. Now, severe is when the HbCO, which is the carboxyhemoglobin, levels are more than 30% in the blood. And it presents with neurological signs, ECG ischemia, and metabolic acidosis. The management is high FiO2, 100% FiO2 until HbCO, which is carboxyhemoglobin, is less than 5% typically. There is some role of hyperbaric oxygen, but it is there's no strong evidence of improving mortality or neurological outcome with hyperbaric oxygen. Plus, they are not very readily available, and there's a whole logistics behind transferring to hyperbaric oxygen. So it's not routinely recommended. The mainstay of treatment is typically high FiO2, which is 100% FiO2, until the carboxyhemoglobin levels fall to less than 5%. Cyanide, which I talked about earlier, but again, I'll discuss once again because it's, again, if there's a inhalational, because it's one of the inhalational toxins, especially if there is a house fire or suspected in burns victims. And it's present, like I said, in pesticides and tobacco smoke and fruit seeds, and released during combustion, that is polyurethane and vinyl, and breakdown of sodium nitroprusside. Suspect in burns patient with metabolic acidosis. So if there's a burns patient who has come in with metabolic acidosis, cyanide toxicity should come to your mind straight away. Severe cyanide poisoning presents with high lactate, very high lactate, high anion gap metabolic acidosis, low arteriovenous oxygen gradient, neurological signs, and cardiovascular compromise. And the management remains is high FiO2, vitamin B12, sodium sulfate, dicobalt editate, and sodium nitrite. Now, how do these individually work? Amyl nitrite, it converts hemoglobin to methemoglobin, that is ferrous to ferric state, and the cyanide binds to HB as a
నీకు ఒక నంబర్ పంపాను ఆ నంబర్కి వేస్తా ఉండాలి ఎవ్రీ మంత్ మన
Okay, can you hear me? Okay, so the amyl nitrite converts hemoglobin to methemoglobin, that is ferrous to ferric state, and the cyanide binds to methemoglobin as higher affinity than, it has got a higher affinity than cytochrome oxidase. So, but the therapy should be titrated to the methemoglobin of 20 to 30%. Next is hydroxycobalamin, which binds to cyanide and converts into cyanocobalamin. Sodium thiosulfate binds to cyanide, which turns it into thiocyanate, which is excreted into the urine. And EDTA, which is cobalt ion, bind to cyanide. But one has to be careful about relative toxicity of cobalt-containing compounds. So these are the mainstays of treatment with cyanide toxicity. Am I going too fast, or are you okay with the pace? Do you have any questions at all so far? Just let me know. Is the pace okay for you? Hi, can you hear me? Okay, fine.
Hey,
Okay, fine. So moving on. So now the next topic is weaponized biological agents. So firstly, anthrax, which is caused by Bacillus anthracis, which is a gram-positive spore-forming aerobic bacillus. Typical clinical features include, depending on the type of exposure, pulmonary exposure, which is the most lethal. It leads to respiratory compromise and cardiovascular collapse, hemorrhagic mediastinitis, and lymphadenopathy. Cutaneous exposure leads to pruritus, rash, and eschar formation. And GI exposure happens because of ingestion of infected meat. Um, Leads to abdominal cramps, bloody diarrhea, toxemia, and cardiovascular collapse. The treatment is typically antibiotics in the form of ciprofloxacin, 500 mg BD for 8 weeks. In children, it's 20 to 30 milligram per kilo per day. Or doxycycline in adults with 100 in adults, the treatment is 100 milligrams again for a duration of 8 weeks. Children 5 milligram per kilo per day, and amoxicillin 500 milligram TDS in adults, and children it's 40 milligram per kilo per day for children and pregnant patients. And prophylaxis of contacts to continue for 8 weeks, and immunization, typically 3 doses at 0, 2, and 4 weeks. Now, the next one is ricin, which is a glycoprotein extract from the beans of castor plant. It inhibits protein synthesis, causing cell death, pulmonary toxicity when inhaled, and ingestion leads to rapid and severe GI upset and death. Now, coming to another topic, which is quite important from an exam point of view, because this keeps coming up, at least in the UK exams, this is quite a favorite topic, which is botulinum toxin. It's caused by Clostridium botulinum, which is a gram-positive anaerobe found in soil and dust. And the routes of entry could be foodborne, wound, intestinal colonization, bioterrorism, accidental or inhalational during toxin purification, that is. So the typical onset is 2 to 4 hours and it peaks at 48 hours. And the mechanism of action of botulinum toxin is it binds to the cell and cleaves the snare proteins, which is the docking protein, which allows vesicles of acetylcholine to fuse with presynaptic membrane. As a result, acetylcholine is not released into the synaptic cleft, and this leads to flaccid paralysis and anticholinergic features. So typical clinical features, if you go on an A to E approach, or like systematic approach, A and B, which is airway and breathing, is typical loss of airway integrity, neck weakness, and type 2 respiratory failure. Cardiovascularly, postural hypotension. Neurologically, there could be diplopia, blurred vision, ptosis, dysphagia, dysarthria, and dysphonia. Enteric or GI system, there could be ileus and abdominal pains, and urinary incontinence as well. Coming to the management, it's mostly supportive care. One has to serially monitor for respiratory parameters. Now, intubation should be done in a semi-elective manner, and mechanical ventilation. And tracheostomy is often required because a lot of them end up staying for a long, long time in the ICU. Diagnosis is confirmed by early toxin bioassay from the feces, vomitus, serum, and pus. Administration of trivalent ABE antitoxin, which should not be delayed whilst confirming the diagnosis. Can be repeated after 24 hours if no improvement. It is a notifiable disease, so one has to notify the local authorities about if there's a suspected case or confirmed case of botulism. And there's a multidisciplinary team approach, including microbiologists, infectious diseases teams. Like I said, they may end up living in the ICU for weeks or months. So several months of supportive care may be needed. Ventilatory muscle strength usually recovers by 1 year, but the exercise capacity may be reduced for later on as well. The mortality remains at 7 to 10%. Now, acute radiation sickness, which is the next topic, which is basically whole body irradiation or significant exposure to radiation. It is typically dose dependent, and the onset is several hours to weeks following exposure. Now, what are the criteria for acute radiation sickness? Large dose, for example, greater than 0.7 gray or 70 rads. It's an external source, penetrating and delivered in a short time. What are the typical stages of acute radiation sickness? Usually starts with prodrome, which is nausea, vomiting, anorexia, diarrhea, which could last from minutes to days. Latent, that is appearance of health, hours to weeks. And then there's manifest illness, which is syndromic symptoms, hours to months, which is then followed by recovery or death, which typically the time ranges from several months to 2 years. What are the manifestations? Typically, the systems that are involved are bone marrow, GI, and cardiovascular and CNS. So bone marrow syndrome, which is greater than 0.7 gray, leads to bone marrow destruction, infection, hemorrhage, dose-dependent increase in mortality. GI syndrome, which is greater than 10 gray, leads to GI destruction, infection, dehydration, electrolyte disorders, lethal within 2 weeks. And then cardiovascular CNS syndrome, which is greater than 50 gray, and it leads to circulatory collapse, raised ICP due to cerebral edema, vasculitis, and meningitis. It's fatal within days. What are the management priorities in such cases? So prompt triage, identification, and support, treat contamination, management of concomitant burns and trauma, and expectant management or palliative care in some cases. Now that brings to the end of environmental hazards. The next topic is toxicology or poisoning. So before I move on, is there any questions at all or anything that you want to discuss? You can pop it onto the chat. No? Happy for me to move on then, yeah? Okay. So I'm moving on to poisoning or toxicology, which is quite a big topic, and I've tried to cover as much as I can in this. So how I'm going to discuss this topic is, so overall overview of poisoning firstly, which is presentation, which is how do patients present with poisoning to the ICU, either as an accidental overdose or intentional overdose, recreational intoxication, or a patient of trauma who has been involved in poisoning as well, deliberate poisoning, and a chemical weapon of use. It should be a differential in patients with altered physiology on reduced level of consciousness. So if there's a patient who's come, who needs to be assessed, who's come with altered physiology and reduced level of consciousness, poisoning should be in one of the top differentials. Now, what is the initial approach to a poisoned patient? Firstly, history, like with any other patient, but obviously the history has to be via a collateral history, for example, from family or paramedics. Try to identify the poison. If there has been co-administration with any other poison, or 2 or more poisons involved, or for example, alcohol is involved as well. try and quantify how much poison has been taken, the timing of the event, and if there has been a trigger event, for example, in mental health or any past medical history, which might guide us towards investigation and further management. What are the 5 principles of management of a suspected poisoning? Firstly, resuscitation, identification of the poison, drug manipulation to limit the absorption, specific antidote, because a lot of the poisons have specific antidotes, some of them may not have, and then definitely supportive care, as with all ICU patients, and seek early specialist advice as well. Examination wise, look for toxidrome features. So I will tell you more about toxidrome features as I go along. Signs of organ failure or complications, for example, pulmonary edema, aspiration, dehydration, and signs of secondary trauma, for example, fall or head injury or wounds, which could result from a poisoning. Investigations wise, obviously, you do your basic observations that you would do for any patient: full blood count, kidney function tests, liver function tests, glucose, clotting, creatinine kinase, and osmolar gap. Definitely very important not to forget a 12-lead ECG, because that might give us a number of clues. Imaging or relevant investigation to differential diagnosis, for example, consider a CT head, and toxicology studies, for example, paracetamol and salicylate levels and iron studies. Now, what are the management principles? So general management principles for in cases of poisoning include firstly reduce the effect of the system effect of toxins. Seek advice from specialized centers. For example, in the UK, there's National Poisons Information Center, tox-based pharmacy, supportive care of other organs or organ failure. Consider other differentials as well, and refer to mental health teams, police, or safeguarding teams as well. Now, toxidromes. So, 1 second, please. Yeah. So, toxidromes, as I mentioned, it is signs and symptoms, typical like a collection of signs and symptoms that happens when certain poisons are ingested. So, toxidromes can be cholinergic. Now, what it does to pupils is it causes meiosis. Neurologically, it causes sedation or seizures, and it might lead to bradycardia and hypotension. And if you remember, this causes typical sludge syndrome. It stands for salivation, lacrimation, urination, defecation, GI upset, and emesis. And the causes include organophosphorus poisoning, nerve gas, neostric beam. And the second one is anticholinergic, which is typically causes the pupils to go into mydriasis, which is dilatation of the pupils. Neurologically, it causes agitation, sedation, seizures, and coma. May lead to tachycardia, hypertension, and hyperthermia. Others, for example, anti-secretory or urinary retention, and the causes include antihistamine, tricyclic antidepressants, hyoscine, atropine, and anti-Parkinson drugs. Sedatives, it causes meiosis to the pupils. Neurologically, it causes sedation. Observations wise, it may lead to bradycardia, hypotension, hypoventilation, and hypothermia. May lead to constipation, and common causes include opioids, alcohol, benzodiazepine, barbiturates, anti-epileptics, GHB, and baclofen. Stimulants lead to mydriasis. Neurologically, it leads to agitation, seizures, and tremor. Observations wise, leads to tachycardia, hypotension, or hyperventilation, and hyperthermia. And it is anti-secretory. The common causes include cocaine, amphetamine, theophylline, and caffeine. Now, what are the measures to reduce the effect of a poison? Firstly, to reduce absorption. by either GI decontamination, which is induced emesis, gastric lavage. It is not very routinely recommended to do the gastric lavage because airway needs to be protected for that. Whole bowel irrigation, isoosmolar solution of polyethylene glycol and electrolytes, used in, for example, iron poisoning. Others include endoscopy and surgery, for example, in body packing. These are all the methods to try and reduce GI decontamination. Adsorption, which is example activated charcoal. Use of a lipid sink, which is intralipids used with lipophilic molecules, used in local anesthetic systemic toxicity, calcium channel blockers. And finally, skin decontamination, which is typical removal of clothes and washing of skin properly. The second method is to enhance elimination by fluid repletion, urinary alkalization, for example, in salicylate, extracorporeal removal, and there could be some role of forced diuresis as well. Neutralization of toxins, use of specific antidotes, and specific supportive therapies. These are all other methods for decontamination. Now, drugs which could be eliminated by extracorporeal methods, for example, renal replacement therapy, they include low protein binding drugs, drugs with low volume of distribution, low non-renal clearance, and low molecular weight. Smaller molecules, which is less than 10 kilodalton, can be removed by diffusion, that is hemodialysis, and moderate size molecules, which are typically less than 25 kilodaltons, by convection or continuous veno-venous hemofiltration. Now, what are the toxins removed by hemodialysis? There's a very nice mnemonic for this, which is I stumble. So I stumbled stands for isoniazid and isopropyl alcohol. S is salicylates. T stands for theophylline or tenormin, which is atenolol. U stands for uremia. M is methanol. B stands for barbiturate. L is lithium. E is ethylene glycol, and D is dabigatran. Right. Now, specific antidotes for particular toxins. Now, this table contains as both the toxins and the antidotes, starting with aminotophyloids, which is typically mushrooms, and the antidote is silibulin. Amyl nitrite is methylene blue. Arsenic, mercury, gold, and lead is dimercaprol. Benzodiazepine, the antagonist, is flumazenil. Beta blockers, it's glucagon. Calcium channel blockers, calcium and insulin, which is HIET, which I'll cover separately as I go along. It's an important topic in itself. Cyanide, as discussed before, B12, sodium thiosulfate, dicobalt aditate, and sodium nitrite. Digoxin is digoxin-specific antibody. Iron is desferrioxamine, like I discussed before. Isoniazid is pyridoxine. Methotrexate, leucovorin. Opioids, naloxone. Organophosphorates, pralidoxine. Paracetamol, N-acetylcysteine, and SSRIs include cyproheptadine. And toxic alcohols, fomepizole and ethanol, which I'll discuss later on as well. So this is the table which is quite important in terms of the toxins and antidotes, which could be exam questions as well. Now, the next topic is psychiatric medications. Typically, they are tricyclic antidepressants, SSRIs, SNRIs, and antipsychotic drugs. Now, tricyclic antidepressant overdose is fairly relatively commonly seen, and it is also a very typical exam question. So this is it is basically how do they present and their management and all of that. So this could come up as a theory question as well as later when you do your viva. So TC overdose is a very common exam fodder, really. So it presents with anticholinergics and toxidrome, like I discussed earlier. And dysrhythmias are quite common because of sodium channel blockade. hypotension, seizures, reduced consciousness, and delirium. That's how they present. Now, typical features of an ECG is tachycardia, right axis deviation, Brugada type 1 pattern, broad QRS complex, which is more than 100 microseconds, typically increases seizure risks, and more than 160 milliseconds increases chance of ventricular tachycardia risk, and it also prolongs the QT interval. Now, this is typically how a TCA overdose will present. Now, if you look at the AVR over here, it shows the R wave that you see here in the AVR is very typically what is seen in a TCA overdose, an R wave like that, the one that it looks like that. And other features you can see is tachycardia, you can see a right axis deviation. So this is a very typical ECG of TCA overdose. This keeps coming up in the exam, which is why I thought I would just put it on my slides. Management wise, so obviously these patients need to be managed in an area which offers cardiac monitoring. Management of sodium channel blockade. Now the specific antidote is sodium bicarbonate, and when you use it, it's if there is seizures or the QRS is prolonged to more than 100 milliseconds and hypotension. Use of lignocaine if refractory to bicarbonate. If there's ventricular tachycardia, again, bicarbonate can be given along with lignocaine, magnesium, and intralipid. Of note is you normally tend to give amiodarone if there's a VT, but it can cause further prolongation of QTC. They may need intubating and ventilating for seizures or respiratory acidosis, or there could be other indications as well, for example, loss of airway reflex. Now, SSRI overdose, which is often benign, it leads to development of serotonin syndrome, which is again a very frequently asked question or frequently asked topic in the exams. So I'll talk about it later on my slides as I go along. Citalopram and escitalopram, it causes dose-dependent QT prolongation, and therefore there's a risk of torsades points. Antipsychotic overdose. So butyrylphenones and phenothiazines, for example, haloperidol and chlorpromazine. So what are the symptoms and signs they present with, which is fluctuant mental status, CNS depression, tachycardia, hypotension, urinary retention, and anticholinergic syndrome. And atypical, for example, olanzapine and risperidone, they present with CNS depression, hypotension, and seizures. The management of antipsychotic overdose, use of benzodiazepine for agitation. Intubation may be needed while sedatives are eliminated, and delirium on emergence and mitigation strategies. Anti-delirium care and alpha blockers like dexmedetomidine, and management of withdrawal. Now coming to lithium toxicity. Now lithium toxicity, it's important because lithium has got a very narrow therapeutic window, which is basically the dose at which it is effective as a medication versus the dose at which it starts showing toxic effects. There's a very, very narrow window between that. Can be present as acute or chronic symptoms. Acute is basically leads to GI symptoms, which then onwards leads to neurological symptoms, whereas chronic is more common due to renal dysfunction and presence with neurological issues. Management of lithium toxicity, specific investigations, for example, lithium levels and thyroid function tests. Establish and treat the cause. Example, if there's a acute kidney injury, treat the acute AKI, and fluid repletion.
जो है उतना ही देना, 16 मिनट दे दो
और ट्रेसी वन और दोनों 6 मिनट 10 मिनट
वो सब दे दो.
So dialysis, the guidance varies. Lithium levels, if it's more than 4 to 5 millimoles per liter in acute, and if the levels are more than 2.5 millimoles per liter if it's chronic, and the extent of neurological and cardiac features, the trajectory of the illness, and renal dysfunction. So there's no universal guidance, but these are the things that one has to take into account if you are thinking of dialyzing a patient with lithium toxicity. Now, recreational drugs. Common drugs of abuse, they include narcotics, for example, heroin, fentanyl, and tramadol. Depressants, for example, benzodiazepines, barbiturate, and gamma hydroxybutyrate. Stimulants, for example, amphetamines, MDMA, and cocaine. Hallucinogens, for example, synthetic cannabinoids, example, spice, ketamine, and phencyclidine. And anabolic steroids, for example, testosterone and modified derivatives, example, stanozolol and oxandrolone. So these are the recreational drugs which are quite commonly seen in the critical care practice. Now, what are the principles of management of an agitated and intoxicated patient? First and foremost is maintain safety towards staff and continuous assessment of capacity and ability to comply with management. There should be strategies for rapid tranquilization, antipsychotics or ketamine, use of GA, for example, in head trauma needing CT and severe hyperthermia. Manage the underlying cause of agitation, for example, urinary retention with anticholinergic agents, and consider differentials. Manage complications like serotonin syndrome and sympathomimetic syndrome. Now, toxic alcohol ingestion. I think I'll just do this topic and I'm going to stop it here. And the next topic I'll carry on from the next class. So toxic alcohol ingestion is ethylene glycol, which is usually an antifreeze, detergents, and metal polish. Alcohol dehydrogenase metabolizes to glyoxylic acid and oxalic acid, which typically causes a high anion gap metabolic acidosis, or a HAGMA. Now, the stages, in the first 2 hours, it's usually GI upset, ataxia, nystagmus, and seizures. Within the first 24 hours, it's usually cardiopulmonary, that's myocardial dysfunction. Patient may develop multi-organ dysfunction, ARDS, and shock. Within the first 72 hours, AKI because of the precipitating calcium oxalate crystals in the kidney. And more than 72 hours, it's late neurological sequelae. It leads to external ocular paralysis and cranial nerve defects. Methanol, which is a vapor fluid antifreeze accidentally produced during home distillation, metabolized by alcohol dehydrogenase to formaldehyde, and then aldehyde dehydrogenase to formic acid, which is a mitochondrial toxin, again leads to a high anion gap metabolic acidosis. The stages, again, it starts with GI upset, dizziness, and ataxia. Then there may be a latent phase, which may be asymptomatic. Then there could be a snowstorm vision, which because of optic nerve atrophy, cerebral edema, basal ganglia hemorrhage, and respiratory arrest. Isopropyl alcohol or isopropanol metabolized to acetone. GABA agonism in CNS and GI irritation. Features include hemorrhagic gastritis, cerebral signs, and coma, and management is supportive. Now, what is the specific treatment? Antidotes. The antidotes for all these cases of alcohol poisoning include ethanol and fomepizole, which is an alcohol dehydrogenase inhibitor. Sodium bicarbonate to maintain the pH between 7.35 and 7.45. Cofactors may be given to produce less toxic metabolites. For example, use of pyridoxine and thiamine in ethylene glycol, and folate and folinic acid in methanol. Now, fomepizole, which is the specific antidote in such cases. What are the indications? The typical dose is 15 milligram per kilo. It's used when the serum concentration of the alcohol is more than 20 milligram per deciliter. Ingestion confirmed or suspected with 2 of osmolar gap, which is greater than 10 milliosmoles. pH is less than 7.30, and bicarbonate is more than 20, and presence of urinary oxalate crystals. Now, indications for hemodialysis, that is metabolic clearance, include serum concentration of more than 50, arterial pH less than 7.25, presence of visual disturbances, AKI and refractory electrolyte abnormalities, and refractory hemodynamic instability as well. Right, I'm going to stop here now for today, and then I'm going to carry on in the next class, which will most likely be in July, because the next few days up until July first week or so, I'm very busy with on-calls and duties and things like that. So I'll come up with a date and I will let First Academy know, and then we can start with where we left off. So I'll complete the rest of the topic in the next class, and then I'll also come up with some MCQs which we can go through together. I'm going to stop sharing now.
Thank you, sir. We will schedule the next class in July. If anyone have any question, they may ask now.
What are the poisoning left? Well, there isn't much left really, because I've covered more than half of what I needed to cover. Yeah, there isn't a huge lot left. Anyone else? Okay, sometimes many pesticide poisoning cases come. Fine, I can discuss that later, like in the next class then. Okay then. Okay, if there are no more questions, I will end the class today here. And when I have a date for the next class, I'll let First Academy know, and then we can take it up from there.
Thank you.
Thank you very much. Okay.